Thank you so much, everybody, for being here to hear Professor Leskovic's talk. Thank you so much on behalf of everybody here at Penn State. Thank you so much, Jure, for joining us. Today, we're very fortunate to have with us Professor Leskovic, who's an associate professor of computer science at Stanford University. He's also the chief scientist at Pinterest and an investigator at the Chan Zuckerberg BioHub. He co-founded a machine learning startup Kose, which was later acquired by Pinterest. Professor Leskovic's research area is machine learning and data science for complex, richly labeled relational structures, graphs, and networks for systems at all scales, from interactions of proteins in a cell to interactions between humans in a society. His research applications include common sense reasoning, recommender systems, social network analysis, computational social science, and computational biology with an emphasis on drug discovery. His research has won several awards, including a Lagrange Prize, a Microsoft Research Faculty Fellowship, the Alfred P. Sloan Fellowship, and numerous Best Paper and Test of Time awards. It has also been featured in popular press outlets such as the New York Times and the Wall Street Journal. Professor Leskovic received his bachelor's degree in computer science from the University of Ljubljana, Slovenia, and please forgive me if I butchered that pronunciation, in machine learning. And he received his PhD in machine learning from Carnegie Mellon and postdoctoral training at Cornell University. With that, Professor Leskovic, please feel free to get started whenever you're ready.
Okay. Thank you. Thank you so much for the invitation and excited to talk to you today. So what I plan to talk to you about is this project we've been working on now for over a year about building super high resolution, super accurate models of COVID-19. And really contributing to the way how we are fighting the pandemic and how public policy is being shaped by use of such models. So really, the lecture today will be about a paper we published in Nature back in November of 2020, and is work by three amazing students, Serena, Emma, who is now assistant professor at Cornell, and Pangwei, who will be on the job market next year. So they are amazing computer science students who did all this. So let's go back a year, and it was March 2020, and there was the coronavirus outbreak. And some drastic measures were taken, right? Stay at home, social distancing, lockdown, masks, all that. And there was also a lot of contradictory information. Even WHO not recommending wearing masks at the beginning, various countries and the various leaders taking very different approaches into fighting the pandemic and facing it. So, and of course, all these measures and this uncertainty and misinformation and so on led to a lot of also like demonstrations and clashback by the society, by the people all over the world. Right here, I have some photos from Germany, Spain, United States, United Kingdom, and essentially all over the world. Right. So really what I kind of want to say is it was a huge kind of surprise how this all hit us. And there was a lot of unknown and really wasn't clear what is the best way to face this, what is really happening. And this is where our group, we really came in, stopped quite a lot of research projects in the group and said, hey, can we do something as computer scientists, as data scientists, as machine learning people and really help here? And this was really our motivation and thinking back in March 2020. And we were really interested in building better models and providing some important answers that were unknown at that point in time. And one main realization that you have to keep in mind is when you are doing modeling is that modeling is super hard. And the reason why it is super hard is because the underlying world and the dynamics of the world and human behaviors change all the time, right? So the models kind of operate in this highly non-stationary, highly dynamic, highly volatile world that is changing from an hour to an hour. So this was really kind of the situation when you are trying to build models. So we said, okay, let's make a step back and let's reason from the first principles as computer scientists, as computational people, as data scientists, and really build a simple model that will take us very far, and it will allow us to answer important open questions, and will also act as a tool for policymakers. So here is how, our thinking started. Right? If you say, I have a virus, including a coronavirus, then viruses spread through human contact, right? A virus kind of jumps from a person to person when two people are in contact. So this means that there is this underlying network that, that describes who's in contact with whom. And the contact network is really the medium over which the virus spreads. We may not see this contact network, maybe it's unobservable, impossible to measure and all, but it's still there. We may just not see it. And then if you have this contact network, then a simple epidemiological model is the following, where basically you say that an infected person can infect her contact with some small probability beta, right? So a virus may jump from an infected person, from an infectious person to a susceptible person with a small probability whenever there is a contact, right? And then, of course, if you say, how is the virus going to spread in one part of the network versus the other part, it will be quite different depending on the structure of the neighborhood of the network around that person. And one of the main problems in epidemiology is that these contact networks, these underlying networks over which the virus basically spreads like a contagion, are unknown, right? We don't know whether the underlying contact network is like here on the left, or is it more like the one here on the right? And of course, this has huge implications on the way the virus would spread, because if the network is very well connected, the virus is going to spread faster than, if network is very sparsely connected and there are only a few chances for the virus to spread from one person to the other. So the contact network is unknown. And what computational models of virus spreading do today is they assume the network is fully connected, right? So that basically any person can infect any other person. And maybe this is okay if you are modeling a household and say anyone can infect anyone, or maybe if you model a very tiny small community. But if you want to model entire United States, then a person coughing in San Francisco won't get a person in New York infected, or at least the probability of that event will be much, much smaller than, I don't know, a next door neighbor getting infected by that. Right, so the networks not being there and not seeing this thing is a major hurdle. And really, where we started was to say, how could we accurately estimate this fine-grained dynamic contact network for, let's say, a population of 100 million people? Right? Could I do this fine-grained dynamic who's in contact with whom network for 100 million people? And our premise when we came into this was the following. If we can estimate this network, and if we build statistical tools to estimate this dynamic contact network, then using this model, we'll be able to answer a lot of different questions. We'll be to answer questions about, do social distancing, does it really help? Is stay at home important? Where, at what times of the day, in what locations do people get infected? How can we reopen economy? How can we reopen different parts of businesses so that we keep the infections at check? And all this we'll be able to achieve with our model, because we are able to, as I will show you, able to model contacts at these fine-grained resolutions in real time as the world is evolving. And because we get this information and we see how this contact network is, this means our models are accurate. And even if because they allow us to capture the change in the population behavior, which was changing rapidly and wildly in the parts of March and especially in the first wave. Okay, so what are we going to do is we are going to use cell phone data. So basically the cell phones we are carrying in our pockets and their locations to estimate the human contact network. So you can imagine that basically if we can get some rough estimate of what are the locations of cell phones during the day, then we can kind of try to estimate what cell phones are near each other, and this way get a good estimate of what is the underlying human contact network. And we are going to do this for 10 largest US metropolitan areas, 100 million people, and we are going to estimate the contacts between cell phones for every hour of the day. So we are going to have a new contact network for every hour of the day, you know, over weeks, months, perhaps even years. Okay, so that's the high level idea of our approach. So our work is to really estimate this human contact mobility network. Sorry, I'm a bit confused. Just a second. I'm sorry. These slides seem to be a bit out of order. Sorry. I'm not entirely sure what is happening, but maybe they should be this way. Okay, now this is better. So let me tell you what we build and what data we used. So the data that we used to build this contact network.
You haven't reshared your screen.
Apologies. Okay.
Yeah.
Good.
Better.
Yeah. So so we want to estimate this contact network, and we will estimate it from cell phone data. So the data we use is coming from a company called SafeGraph that has agreements with different cell phone application developers and providers, and then collects anonymized aggregated location data from many cell phones, and then estimates where these cell phones are. And this data, as I said, is anonymized, aggregated, and comes from these business relationships that the SafeGraph has. And what was nice is that SafeGraph made this data freely accessible to researchers. The data is still accessible at the following URL, and basically gives us this raw data gives us a way to actually estimate the mobility of the population. So we were going to use this raw SafeGraph data to infer the mobility network. And the way we are going to infer the mobility network is that we are going to model two types of locations. We are going to model the points of interest, which are different types of stores, places, parks, grocery stores, pharmacies, coffee bars, hotels. So basically anywhere that people like to go to. And we are using over 500,000 different points of interest across these 10 largest metropolitan areas. Here, every yellow dot is a different point of interest, right? So basically you can see kind of nicely follows them. You can see the metropolitan areas, you can see the population density of United States and so on. And then our goal will be to model mobility at two levels. One will be to model the level at the level of points of interest, as I mentioned, and here I show you different types of categories of points of interest that we consider. Anything from pet stores to hardware stores to beauty salons to jewelry stores to sewing and piece goods stores and libraries and so on. And then we are also going to model the other type of location, which are neighborhoods. These are called census block groups, and these are areas where around 600 to 300 different people live. And what we are going then to model or capture is how people from different neighborhoods visit different points of interest. So for every hour of the day, we are going to estimate how many people, we don't know who, but how many people from a given neighborhood visited a given point of interest. So this is, an individual Trader Joe's in, I don't know, Palo Alto downtown, or this is an individual coffee shop on Manhattan on this particular address. So these are really individual stores, individual grocery stores. This is not just saying, oh, grocery stores all together. It's an individual grocery store. And for every place, we know its square foot area, so we know how big it is. And we also know how long people tend to stay there. So what is the duration of the visit? Okay, as I mentioned, we have points of interest and census block groups. And we have this model that will, this network inference procedure that for every hour of the day estimates how many people from a neighborhood visit a point of interest. We have actually built a big network inference algorithm that takes data from SafeGraph as well as from the US Census and through the iterative proportional fitting, estimates this network for every hour of the day. And this is a kind of a big pipeline that takes the different data sets and estimates the network of how people from different neighborhoods visit different types of places. We also then integrate, especially for the second modeling, the second wave, also data about daily mass queues. And at the end, our models over 500,000 points of interest, nearly 60,000 different neighborhoods, and has over 5.4 billion edges. And as I said, this network changes every hour of the day. Here is some statistics for the 10 different largest US metropolitan areas, number of different neighborhoods that are, so these are census block groups, units of US census, number of different points of interest, number of edges in in our bipartite mobility graph, total size of the modeled population, as well as the total number of visits of people to those places. This is the data from March to May 2020. And just to give you an idea, here is Washington, DC area. At the bottom are different neighborhoods. At the top, every dot is a different point of interest. And a line means that somebody from that neighborhood visited that point of interest. And again, when I say visited, I really mean this was inferred through the raw mobility data on a much smaller population and through our mobility model and extrapolated to 100 million people. So this is not really that we are tracing individuals, but it's more an inferred through our statistical procedure that we have developed. But this is the mobility network on March 2nd, so just before the pandemic, on Monday at 1 p.m. And, you know, here is April 6, Monday, 1 p.m. And just, you know, if I go back and forth, you see how different these networks are, right? You see that how on April 6, there is much less mobility than it was on March 2nd. The second thing you notice is that most people visit places that are close to their neighborhoods. So these lines are vertical and these diagonal lines would correspond to commutes, right? Like you, from the suburb, you commute more closer to the center of the metropolitan area. So now this is the mobility data and what our inference engine allows us to do. So now we need an epidemiological model on top of this. And we have decided to build a SCIR epidemiological model that basically models how people move between states. And states are susceptible, exposed, infected, and then recovered, which would mean immune or in our case. And we have opted for a very simple epidemiological model so that we really show the power of our approach. So our model will only have three free parameters that we calibrate or fit on the data. And these three parameters are probability of virus jumping from a susceptible from an infectious to the susceptible person at points of interest. And this is the same for all different points of interest. And then also the probability of getting infected, of virus jumping inside a given neighborhood. And again, this is the same for all the neighborhoods. And then, you know, the model has to start with a certain, with some people already infectious. So we need this P0, which is initial fraction of infected population. Again, we would have this to be the same across all neighborhoods. So the model really has three basic parameters that I just described. So what I want to do next is give you a high-level idea how the model operates. So the way the model operates is that we have this bipartite neighborhoods to points of interest mobility network, and we are going to initialize, based on the census data, a particle for every inhabitant of neighborhoods, right? However many people live in a neighborhood, according to the US Census, we are going to insert those particles into the neighborhood. This is kind of more for illustration how the model works. In reality, we don't necessarily create these particles, but this is the idea, right? So, and now because we have we have one particle for each person. And given that we know the P0 fraction of infected people, for every neighborhood, we would infect a given fraction of people at random, so that our model can start with some infectious people. Now, given that we have the mobility network for that given hour of the day, we would select a random set of particles, and according to the mobility network, we would move them into the points of interest. At the point now, these people at the points of interest from different neighborhoods meet with each other, they mix, and they can infect each other. And these infections of basically virus jumping from infected red people to the susceptible gray people considers both the dwell time, so how long the visit takes on average, and what is the square foot area of the place, so how densely people are packed there. And now, right now, I have a few infectious people at these points of interest, and a few more gray circles became red. And now, so the people mixed and infected, and now they travel back home. So according to the mobility network, the particles move back home. And then again, at home, in the home neighborhoods, these particles can mix and infect each other a bit more with this beta neighborhood probability. And now, again, the network updates. It's the new hour. Again, we select some random particles and move them back to the points of interest, where again they mix, they can infect each other, and they move back. So that's the model kind of at high level. Here is model in terms of equations, right? We simulate these epidemics hour by hour, how it unfolds over our dynamic mobility network. We start with a certain number of certain fraction of infected people in each neighborhood. So this is first parameter, and this is the same fraction across all neighborhoods. And then basically what we do is that people from neighborhoods visit POIs, and they mix with each other at POIs, where infectious people can infect susceptible visitors with this POI parameter that is a scalar and the same for all different points of interest. But what is different for different points of interest is the dwell time, the median duration of the visit, as well as the square foot area. So this is point of interest specific, while this parameter is the same for points of interest. And now certain people get infected, and then they return back home into their neighborhoods, where again infectious people and susceptible people in that neighborhood interact. And again, there is another parameter, kind of a background probability of infection, so that in neighborhoods people get infected as well. And again, this is a scalar, so all neighborhoods get the same parameter. So this is really kind of a very simplified model of the infection. The model has also other constants that we set and did not fit. We simply set them based on the literature recommendations, like the mean latency period, mean infectiousness period, period from getting infectious to confirmed, because it took time for people to get tested. Actually, what is the fraction or percentage of cases that are truly detected? We used 10%, right? So there is all these constants that you need in your model to truly model the progression of the disease, because it unfolds over time. And here are some of these constants. These are the three free parameters that we actually fit, and the rest is basically set based on the values in literature. And it may be oversimplifying, or it's quite simplified. The real epidemic is much more complex, but this is what we decided to do. So our full pipeline basically takes the raw input data from SafeGraph and US Census, builds these hourly mobility networks, over which we then overlay this epidemiological model with us that has a fixed set of constants, as well as 3 scalar parameters. We would then calibrate the model on observed case counts or death counts as reported by the New York Times, because they have reports at the county level. And then we would obtain best parameter fits to run our simulations. So the way we calibrate the model is that basically we do a grid search over these 3 parameters and say, here is the, the way this works is x-axis is time, y-axis is daily confirmed cases. The gray axes are the case counts reported by the New York Times. The orange line is just a guide to the eye, and it's kind of the moving average over the gray axis. And then, for example, here would be the run of the model, where we would use a part of the data, so the first few weeks, to calibrate the model and then see how well is it predicting the future trajectory of the pandemic. We did the grid search over 1,500 parameter sets, and we selected parameter sets whose error is within 20% of the best error. And error we simply measure using the root mean square error. So that was our fitting procedure. And really, right after we've been working on this for quite a long time, and kind of in the middle of pandemic, we felt that there are many other groups in the world having exactly kind of the same idea and working on the same project and the same problem. So we were very much kind of, anxious and biting our nails. Will all this work out, right? Did we just throw away half a year of our work, or is this actually going to work out? And will it be able to fit the pandemic accurately? And what we find out is that these models fit quite well, right? So that basically this mobility seems to be very important in us being able to fit the trajectory of the pandemic well. Here I show you an example of Chicago, but perhaps more importantly, the same model can fit all these different US metropolitan areas accurately. And what is important here to note is that the trajectory of the pandemic in different cities was very, very different. If you think of New York City, there was this huge outbreak and then they got it under control. If you see, for example, Philadelphia and San Francisco, it was a ramp up and then basically it remained stable. If you look at, I don't know, Dallas, Washington, DC, it was on the ramp up. Atlanta, you see how noisy their measurements were, right? Another thing to notice here is how bad quality the original data is and how much uncertainty even about the case counts is in the data. You see these raw case counts to which we are fitting basically just wildly jumping around. But kind of our model, even though it is so simple, it has 3 parameters that remain fixed over time, right? Even though the human behavior, the mask wearing, hand washing, all that changed drastically over time, our model is able to fit these different case curves, these different trajectories of the pandemic quite well, right? It's not perfect, like, I don't know, the case of Houston and so on, but it still is able to capture this diversity quite well. So to give you an illustration, here is how this works I give you an illustration for Chicago, where the graph here on the left is mobility. It's simply for every hour of the day for this first wave, which is 63 days, it is the total number of visits to points of interest. This is Chicago, March 5. How people are visiting. You see around 1.8 million visits to points of interest per day. And here you will see the trajectory of the pandemic. This is logarithmic scales. Susceptibles are up here on the top. And then, we have the people in infectious state, people that were exposed. And here is the fraction of people ever infected for the Chicago metropolitan area. Notice here's kind of Chicago downtown and what we think of Chicago, but the metropolitan area is much bigger. Every area here is a census block group, and you will see how now everything is blue. Very, very low fraction of population is infected, and then you will see how this is going to jump up and getting red as the simulation will unfold. So now you see, we are now approaching kind of mid-March. People are really starting to socially distance, and notice how the mobility dropped from 1.8 million visits down to about 500,000 visits per day, and then it kind of climbed up perhaps a bit. Notice how now a higher fraction of people got infected. Notice how there are certain neighborhoods that are dark red where there were really predicted outbreaks, and that there are some that are still quite green. And this is kind of how the mobility is going. These are predictions of our model, and here is what is happening in the map. Right, and you see now how more and more people are getting infected, especially in the downtown and so on. So this is really an illustration of what our model is able kind of to do at high level. But really where our approach really provided new insights was because we can use it to simulate what-if scenarios. So our model allows us to answer question about, what is the impact of stay-at-home and social distancing? What are there, for example, super spreader locations? Our work was actually the first one to credibly establish the risk different places pose to the infection. And also our work allows us to evaluate different strategies for reopening the economy, which was very important, and a lot of different states and counties used our models to actually inform their reopening plans. So let me give you some insights into our model. So the first question is, right, if you look at the data, this is about relative foot traffic over the time to different types of places. And you can see, for example, how this is movie theaters, how it dropped, and blue is airports. And you see, for example, for supermarkets, there was actually a spike just before the lockdowns, and kind of then it dropped a bit, but never really too much, and so on and so forth. So the question was at that point in time, is all this social distancing really necessary? Do we really need to kind of shut down the economy? Were we able to stop the virus by doing this, or not really? And what we find out, right, is that our model allows us to do this because we can simulate different mobility patterns and say what would happen if our mobility wouldn't drop. What would happen if we would drop the mobility only for a fraction of what actually happened? And we can then observe the model's response and use that. And what we basically find out is that stay-at-home was super important. With no reduction in mobility, a third of the entire population would be infected within a single month, right? So if a year ago we wouldn't stay at home, but we would kept living as if it is end of February forever, we would get a third of the population infected. So what I show here is simulations by the model. Black is the actual number of cases. This is what yellow is what would happen without any reduction in mobility. So we see this kind of huge orders of magnitude difference between reality and what would it happen if we wouldn't stay at home. So it was super important. What we also find, and this is especially, I think there was quite a bit of nervousness, if you remember, between different states, or especially in Europe, where there is a lot of different countries, about certain countries announcing lockdowns, other countries not. A lot of people asking, hey, are we going to all be sick because our government hasn't yet locked down, or why do we have to lock down? How about if we wait for a week? And what we find out is that these differences in a couple of days up or down, before or after, don't really make such a big difference early on. And really the exponential function kicks in with the mobility reduction, and not so much on the exact date that mobility happens. So this is one set of analyses that our model was actually the first one to provide these insights that before were just unknown, or were just kind of a speculation, or a hypothesis, but now we were able to rigorously evaluate them. The second thing our model really allowed us to do for the first time was understanding the impact of different types of locations and different types of events on the spread of the pandemic. So what our model does, it models the infection rate at POIs to depend on the number of infectious visitors at a given point of interest, the number of susceptible visitors, the area of the point of interest, as well as the dwell time people at that point of interest. And this allows us to rank points of interest by the predicted number of infections that would happen there according to our model. And the first thing we find out is that there is kind of huge differences across points of interest, that it's only about 10% points of interest that account for 80% of all infections. So it's really a small set of points of interest where our model predicts most infections happen. And these are points of interest where people are crowded together in a small space for long periods of time. We also then can group points of interest based on their category and say what fraction of infections is predicted to happen at those points of interest if they were to be fully reopened, and people would return back to them as if nothing is happening. And we see that actually it's the full service restaurants who would be kind of the biggest generator of infections, followed by kind of the next category of fitness centers, coffee bars, snack bars, and hotels and motels. Then we see limited service restaurants, and we see kind of that places of worship are kind of way down, still relatively high, but way down. And then, you know, other kind of types of places with much less impact. So this was actually the first rigorous evaluation and the first rigorous way to say and to evaluate the risk and the fraction of infections happening at different types of places. And then the last thing I want to mention, another thing that I want to mention, the third one about our model and its ability to really evaluate various types of reopening scenarios for the economy. And by basically what we can do is we can simulate various kinds of economy reopening scenarios by changing or manipulating the mobility patterns of the people. So we can simulate the full reopening. We can simulate various occupancy capping scenarios where we say at any point in time in a restaurant you can operate at, let's say, 25% of maximum occupancy. Or we could say what happens under uniform reduction of visitors to a given place. And this really is important because reopening the economy is a very complex problem, trying to balance between livelihoods of people, so basically jobs, keeping the number of infections down, so kind of public safety, stress on the health system, as well as kind of population well-being. So our model was the first to really allow us to rigorously evaluate these complex trade-offs and assess the economy reopening and the connection to the number of cases. So what we found out is that actually there is this very highly nonlinear effects that happen when you can reopen the economy. Basically, this complex graph I try to show here really summarizes it. But basically what we find out is that a small reduction in the number of visits can lead to a big reduction in the number of infections. So the way to read this is y-axis is the number of new infections, and the x-axis is number of visits to points of interest. So this is over all points of interest. And y-axis, and the numbers are occupancy capping. So if you keep everything open at 100%, then then you will have this much foot traffic and this many infections. But now what this number says is, for example, what if you reopen the economy at 20% maximum occupancy? So you say at any point in time in a given store, in a given restaurant, there can be at most 20% of the maximum occupancy number of people. What we see is actually you get a great trade-off. You reduce the number of infections by 80%, but you lose only about 40% of the visits. So you lost 40% of the visits or 40% of the business, while you reduced the number of infections by over 80%. So you get this very nice kind of good trade-offs, non-linear trade-offs, where occupancy capping really allows you to keep number of infections at check, while still providing a lot of business opportunity and jobs to the people. So basically what this analysis shows is that reopening the economy is not a zero or nothing, kind of all or nothing, but there are these different knobs that you can play with to say, I'm opening restaurants at 20%, fitness centers at 10%, grocery stores at, I don't know, 50%, or whatever you want to do. You can, using our model, you can assess how many or predict how many infections you are going to have. And then the last thing I want to mention is that our model also allows us to explain the reasons and factors for the emerging social disparities in COVID infections. This is especially happened like in US, for example. It's been observed that socially disadvantaged are at much higher risk of infections. And also in other countries like in Spain and elsewhere, similar observations were made that basically this pandemic had a disproportionately big hit on poor and socially disadvantaged populations. So the question is why? And before we published our work, the prevailing hypothesis was that coronavirus devastates these communities more because low-income communities have all kind of a lot of pre-existing conditions and things like that, and they're just more kind of vulnerable. But our question to our model was the following, right? Like as it has been observed that socially disadvantaged get hit higher by the coronavirus, the question is why? And our model, the first question we ask ourselves, does our model capture this? Because our model doesn't know what neighborhoods are rich, doesn't know what neighborhoods are poor, doesn't know anything. It just has these particles and moves them around. So we wanted first to see, is our model in some sense able to learn or in some sense predict this pattern that has been observed? And then our model may be able to shed light on the mechanisms for this disparity. And the point is, the way we do our model is that we are going to run it totally agnostic about what neighborhoods are, let's say, rich and poor. But then we are going to examine, because we can use the census data to group neighborhoods into high and low socioeconomic status, and see whether our model predicts that more infections will happen in low socioeconomic status neighborhoods. And what we find out is that our model is able to capture this pattern really, really well. We see that that the relative infection risk between high and low income neighborhoods in all different metropolitan areas, our model says that this difference is about 2x. So it kind of says that people in low income neighborhoods have about twice as big infection risk than people in high income neighborhoods. So it captures this pattern without ever us telling it to the model, fitting our model to it. So this is just kind of emergent out of the model. So the question is, why is this difference? And we find out that there are two reasons. First is that low-income neighborhoods saw much smaller reduction in mobility. So here I show for a couple of metropolitan areas the mobility of high-income neighborhoods versus low-income neighborhoods. And you see how high-income neighborhoods were able to consistently decrease their mobility much more than low-income neighborhoods, right? So why does this happen? We don't know. It could be that high-income neighborhoods are able to do more work from home, while perhaps low-income have to go to the factories and elsewhere to do the physical work, and that leads to this disparity. So this could be one explanation. However, what we also find out, and that's very interesting, is that basically that people from low-income neighborhoods also visited points of interest that have higher transmission rates. And we found out that the median transmission rate, for example, for grocery stores is 2 times bigger for points of interest visited by low-income people from low-income neighborhoods than from high-income neighborhoods. And the question then is, why is a single trip to a grocery store twice as dangerous for a low-income individual? And what we find out is that people from low-income neighborhoods tend to visit places that have 60% higher density of people. So they go to places where there is 60% more visitors per square foot, and they tend to stay there longer. So they tend to stay there 17% longer than what high-income neighborhoods do. So it is really the combination of not staying at home and going to more risky places that leads to this disparity between, or is one of the reasons for this disparity between high or low income neighborhoods. And this is all that kind of naturally emerges from our epidemiological model. So let me conclude and kind of give a bit of a perspective on our work, right? So we developed the fine-grained, large-scale model of coronavirus spread based on people's mobility patterns. And our model is super fine-grained and scalable because it models single neighborhood and single point of interest at that level. And we model a large population of 100 million people, and it allows for accurate and fine-grained predictions, as I said, all the way down to single neighborhoods and single points of interest. The important takeaway is that these fine-grained mobility networks are very essential, and they lead to accurate case trajectory as well as mortality curve fits across very different trajectories of the virus across very different metropolitan areas, allows us for capturing micro trends, and also allows us to evaluate kind of responses and more effective and equitable responses to the pandemic. So what are some limitations? First is that, of course, cell phone mobility data does not cover all populations, and it's not perfect, and it's still noisy. But in some sense, it is the best we have, and we really wanted to demonstrate that the data is here and that we can use it, because many, public health departments are still operating with pencil and paper, and it's very hard to make decisions, especially in this dynamic, rapidly changing world without good data and without real-time data. So we showed that the data is available and can make a huge difference. We intentionally have we have a simple epidemiological model, and in exchange for that simplicity, right, we don't include relevant features like asymptomatic transmissions, age-related variation in mobility and susceptibility, hand washing. We incorporated mask wearing and so on. So these factors are important, but even without them, our model already works quite well. With all these things, it would work even better. As I said, conclusions: stay at home had a huge effect. Not all points of interest are the same. Recommendations that came of our work and then were repeated across mass media, I'm sure you heard, so I don't need to repeat. And also, the way policymakers established and are reopening the economy is exactly according to our model. Again, having different occupancy rates seems to be a good way moving forward. We were the first to provide quantitative evidence for these things to happen. And as I said, reopening is a very complex question. So having this kind of tools is gold, because it allows us to evaluate these different trade-offs that are very complex and nonlinear. As I said, we were working very hard to publish, to get the research done, to then submit it to Nature and to publish it. It was published in November of 2020. After the paper was published, we have continued doing the work. Now we have much more extended our pipeline to also include daily mass queues and improve the model. So we are now also able to fit subsequent waves. So for example, this is the fit from November to January. This is the second wave. This is the fit of our, this is Washington, DC, fit of the model to the first wave, fit of the model to the second wave. Notice kind of qualitatively curves are similar, but the daily number of cases is quite different. And these are now models without important components. Like if we don't use the mask data, then the fits are not that good. If we don't use mobility data, the fits are not good. As well as what we had to do is have a variable rate, linearly increasing rate of infections in neighborhoods because people stopped obeying stay at home over time. So in the neighborhood. So these are important components to the model. What we are doing now is we are working with public health departments and building dashboards for them so that they can evaluate various types of interventions. I'll give you a quick demo of something we are working on. Here is kind of for you to get an idea of the tool. Imagine, I don't know, this is Chicago. You could say this is just simulation for first wave. You say, you know, everything is closed. Here is the mobility. Here is the cases. Now you could say, let me reopen the full service restaurants. Then you can see immediately how much would mobility change, how many visits to restaurants would you get, and how would that affect your number of infected people. You could say, as a policymaker, maybe I don't reopen restaurants, but people have to exercise, so let me open fitness centers. And then, you know, this is how many visits, how many new cases. You could say, I'll reopen takeout restaurants. This is what is happening. Maybe I reopen places of worships. Again, this is what is going to happen in Chicago. I could say, let me check similar things in San Francisco. This would be the impact, you know, and perhaps in New York, the impacts would be different, right? So these types of tools allow policymakers to evaluate the effect of policy decisions. So our work also received a lot of press coverage. We gave over 400 interviews, appeared on television, and kind of tried to spread the awareness of the results of our study and how to best face the pandemic. Literally, we impacted millions of people. Governments all over the world literally used the plots from our paper to communicate or justify their policy decisions. US state governors relied on our work, and also US Supreme Court actually cites our work for their decisions in their court briefings as a way to justify the decisions on lockdowns and reopening and so on. So really, this is my talk. Thank you for attending. Thank you for listening. And we have a few minutes to take questions. Just would like to thank to all our students and collaborators, as well as the partners and funding agencies that supported us in this research. Thank you so much.
Thank you, Jure. Thank you so much for the wonderful talk. We do have some time for questions. If you have a question, you can either unmute yourself and ask a question, or you can send something to chat. Anybody? I guess maybe I can get started. So, right. So there's something from, okay, Vasant is saying, thank you for a wonderful talk. So one question that I have had, Jure, is that, you know, in the past year, I've seen lots of models, you know, each with their own flavor on how to model the spread of COVID-19. And many such efforts have not seen the light of the day the way your work has. So I guess, is there, could you elaborate more on what that part of the pipeline looks like, that, you know, once you've done the research that you've done, how do you ensure that it has the impact that it has had with your particular thing? I mean, how do you get this out in reality, as opposed to just it being, you know, part of a research meeting in some university, which sadly has happened. I mean, I see lots of other people have also come up with similar seer-based models for modeling the spread of COVID-19, and yet, so yeah, I mean, if you could elaborate a little bit more about that, that'd be great.
I mean, it takes a lot of effort and a lot of humility to push these things and to kind of work with public health officials, develop these tools, a lot of software engineering, and also a lot of education, so that they can start using them. So, you know, sometimes it was actually easier for us just to do the analysis for them and say, here are our projections, and then they would use that as a basis of discussion. For some states, we actually build dashboards or live tools to do things. It is important, like, for example, these dashboards are not public, but they are private and only accessible to these experts, so that they can make kind of get a sense, get a proper understanding, monitor, and then you know, make recommendations to the politicians who or the executive branch who makes the decisions. We were fortunate enough to have collaborators who enabled us to do this as well, both in you know, both at Stanford as well as our collaborators at University of Virginia, Madhav Marathe's groups. He has a lot. We work with him a lot, right? So this is more than just one group. Really doing this requires software engineering. It requires a lot of effort, and it's beyond a single academic group doing it.
I see. Right. Also, from a model selection perspective, you know, we have these many models. I mean, have you given some thought about, from an impact perspective, does it really matter what model do we use for policy recommendations? Because I would imagine that the policy recommendations would not, I mean, sure, each model would be able to give you slightly different qualitative answers as to what kinds of policy recommendations can you make. For example, with your model, you can answer questions like, you know, how does the number of infections increase or decrease depending on the occupancy rates, right? But you could get similar, you know, answers to some questions of relevance using some other models as well. So from a model selection perspective, there have been several efforts on these SEER models from several groups. Has there been any thought given into which of these models is the best one to look at, especially since all of them have been trained using very little data?
Yeah. I mean, we went forward with a kind of a data first approach. We went forward with a simple model that uses rich data to really demonstrate, right, that kind of this, you know, in machine learning we say unreasonable effectiveness of simple models on big data. Right, and I think that's kind of an answer of that, right? And of course, the model is only as good as the people it is able to convince and as the insights it's able to provide, right? And how much you trust it, right? And I think the simplicity of our approach gave us so much more confidence, right? Because I think we scientists, you know, like to talk about good things and drawbacks, but when you make decisions, you have to either stand behind it or say, sorry, I cannot say. So for example, when working with the public policy people, and even like I think, you know, our work did a lot in terms of communication and just public education and saying, look, this is what the kind of what the data shows. For example, we say nothing about schools. Even though we have some school data and some, we could do schools as well. And even though that was a very kind of contentious topic, we consciously decided not to say anything about schools because we felt we are not certain enough to say, here it is, this is what we say, right? Because like it is, I don't know, it was a bit scary, right? Like in a sense to say, this is how infectious restaurants are, right? We got a lot of emails from restaurant owners and saying, hey, look, this is my life. Or gyms, right? A CEO of Equinox sent us email and said, hey. Wow. So these things are very important. And what I mean is, it is it requires really good science, and requires like a lot of checking and just being very sure, because whatever you put out, it really changes human lives. Right? It's much more serious than, I don't know, deciding what movie you recommend to a user, or what ad they are going to see.
Yeah, that takes so much more.
It is hard.
Yep. Okay, so Justin has the question. So can you talk about what is next for this project? Can the model be generalized for other purposes if it happens the next pandemic?
Yeah, I think what is next is there are research questions, and then there are I think, so maybe the next is a few things, right? I think from public policy point of view, I think it showed how kind of pen and paper a lot of our executive or public health executive branches, and how it is kind of impossible or super hard to make good decisions without good data. So I think at high level, I think this research showed that decisions could be done, that there is data available, that there is kind of digital tools available to face pandemics in a much more prepared way. Right. Of course, it also opened new questions around privacy of people, about this kind of big surveillance of people and so on, and that there is a good healthy debate about that. So I think it also showed how important it is to have this infrastructure research groups at universities who can kind of jump in and start helping. Now, in terms of where is our project going, is we have released all of our code and all of data to public domain, and a lot of people have followed up on our work. And I will say, right, that our work is still standing, kind of, it hasn't been refuted or bugs have not been found and so on. So I think what I'm saying is still true, which is not a trivial fact. Where we are moving is, in terms of research, is understanding the reaction of people to policy decisions, because right, you like as a policymaker, you make a policy decision. At the same time, it's not only the policy decision, it's also the media communicating that policy decision. It is about people tweeting, it is about the president tweeting, and all that affects the underlying population. Right. Another thing that is important is that not all counties, not all states have the same measures. So then it becomes very interesting to understand how population reacts to this. Do people drive across states? Do people go to the nearby county to have a beer because they have the things open and your county does not? So we are trying to build better models to understand how does the population react to the recommendations, so that you really say, here's the recommendation, here's the reaction, and this is what is going to happen.
I see. Interesting. Yeah, I mean, I was hearing this talk by Michael Mina from Harvard, and he has been a proponent of paper-based tests for COVID-19. The thing with those tests is that they're very cheap, they're very quick, but they have a very small, poor sensitivity. And so he was interested in figuring out how do people react, or how would people react if they figure out that they get a negative COVID-19 report from those tests, but those tests are not as sensitive as possible. Would they stop caring that we don't have COVID-19 as well? So yeah, okay, great. I guess we're out of time. Thank you so much, Jure. Unless anybody has any other questions, we can end. Thank you so much, Jure, for that wonderful talk, and thank you everybody for attending. Right.
Thank you so much for having me. Have a nice day and a nice weekend to everyone.
Yeah.
Bye bye.
Thank you. Bye bye.